This is going to be penetrating chest injuries, and we'll be going over that. So I'm going to flip the camera view here. Performance objectives: demonstrate competency in applying an occlusive dressing on a patient with penetrating chest wall injury. Equipment, it lists all the equipment that will be provided to you. Scenario, we have several scenarios to choose from. You will find out what the scenario is when you get to your testing station. The examiner's name will go right there: pass, fail, attempts 1 and 2. The third one really doesn't apply, so we kind of cross that out. You only get 1 attempt. Hopefully you pass it on the first attempt, and if you fail, you have to be remediated and pass on the second attempt. There is no third attempt. Then the performance criteria establishes BSI precautions. Not going to really explain that because we went over that in other videos. Assess scene size up and scene safety. That's your pen man. And evaluate the need for additional BSI precautions. That's your PPE. It also says provide oxygen if indicated, because this is going to be scenario dependent. So based on the scenario that you're given, you may apply oxygen. Of course, you have nasal cannula, non-rebreather mask, and BVM, bag valve mask. You have to know if you're going to apply the oxygen, know the flow rate, also the reason why you're choosing that, and the percentage of oxygen delivery as well. Administers positive pressure ventilation, that's your BVM. Remove enough clothing to expose the entire wound. We'll be going over that. That's going to be part of your EOPA, expose, observe, palpate, and auscultate. List the signs and symptoms of tension pneumothorax. We'll be covering what tension pneumothorax actually is today. And tachypnea, tachycardia, decreased lung sounds, hypotension, tracheal deviation, and JVD. And then finally, we have the performance criteria. During your skills testing for trauma, you will be giving a scenario when you get to the chest area. Of course, when you get to the chest area, you always want to go with the EOPA format: expose, observe, palpate, then auscultate, in that order. You have to expose the area first before you can observe, because there might be clothing or other items covering it. So always expose, then observe before you palpate. The palpation is going to be generally for tick, but not all areas. Like the head, you really don't want to palpate for crepitus. You're just feeling to make sure that there's no injuries on the scalp. But in most areas where there's long bones or hard bones, you want to palpate for tick, tenderness, instability, or crepitus, right? So expose, then observe, then you're going to palpate, then auscultate, in that order. When you get to the chest, you want to observe for 4 things: flail segment, paradoxical movement, sucking chest wound, and impelled object. So a flail segment, when you have a break, you have this middle piece right here that's going to be floating around. So it's going to be popping out and in for that section when you're breathing in and out, and your chest wall is expanding and contracting. You'll see that flail segment there. For a paradoxical movement, it's just unequal or uneven movement that you're going to see. So paradoxical motion might be diminished lung capacity on one side, we'll say the right side. When you expand your chest, due to tension pneumothorax that we're going to cover, it may not expand, but your left side is expanding. It's going to be paradoxical movement there. Sucking chest wound is going to be a hole in the chest wall that doesn't quite make it all the way through, or it may, and it's leaking air into that pleural space. And we'll kind of explain that when we get to that portion of it right here. So you have the chest wall, you have the lungs right here, and this is the person's head laying down right there, okay? So if there's a hole right here, and air is leaking out into that pleural space, it's going to start creating tension and pushing the lungs downward, right? So it's creating pressure, it's pushing the lungs down and collapsing that lung, because there's air trapped in that little pleural space between the lungs and the chest wall. And there's a hole right here. And it's going to make a sucking sound because air is trying to suck in when there's negative pressure. So air is going to be sucking in through that hole and we're moving into that pleural space. It's not really making it into the lungs where we need it. It's collapsing the lungs. So we're not getting good oxygen exchange, because oxygen exchange happens in the lungs, not that pleural space. So when you have a penetrating chest injury, here's a crude drawing of a chest again. This person's head right here. When you have an object stuck right there, you really don't want to pull it out. The only place where you can pull it out actually is the cheek. If there's like a pencil or something, a knife stuck inside the cheek, you can pull it out if there's airway compromise. In the chest, we don't know what it's butted up against. If we pull out that knife or object, it can slice an artery or something else, an organ, do some more damage. So we generally want to keep it in there, and we want to bandage around it to keep that in place, okay? So we talked about flail segment, paradoxical movement, second chest wound, impaled objects. Those are all chest injuries. And when you take a look at your skill sheet again, to deal with a penetrating chest injury, first thing you want to do is place your gloved hand and gauze over the chest wound. Wipe away the excess blood around the wound. Peel off the chest seal. Place the chest seal over the wound. Wound should be in the center of the vented chest seal. So a vented chest seal, what is that? And so a vented chest seal, let's see if I can wipe this again. It's going to look like this. This is going to be an occlusive dressing. So when we take a look at the word occlude, that means to stop. So an occlusive dressing is a dressing that's sealed on all four sides. Right, so it's sealed on all four sides. And the wound is right here in the middle. We seal it with tape. That is an occlusive dressing. It's sealed. A vented dressing is going to look almost the same. It's sometimes in a circle. You put the wound right in the middle, and there are vents that allow for air to escape but not come back in. It's a vented seal. Sometimes it's in the shape of a square. It's the same thing. You'll see vents going off to the side. And the idea is you put this vented seal right on the center, so the wound is in the center, and if air leaks out, it's going to go in through one of those channels. But when air tries to go back in, the flap's going to close and not allow that air to go out. So how that's important is when you have this is the chest here, this is the head, you have the lungs. It's a huge lung there, but when you have a hole right here, air is trying to come in, that's bad. You want to stop it from coming in, so the vents are going to close. When air is trying to escape out of this pleural space right here, outward, we want it to escape. So the vents are going to allow the air to escape. When it tries to come back in, it's going to shut. So we place a chest seal directly over the wound. It should be in the center of the vented chest seal. Applies oxygen if indicated. And so how would we know if it's indicated? Signs and symptoms of shock, perhaps. Make sure you know the signs and symptoms of shock. Applies an occlusive dressing and seals 3 sides if no chest seal is available. So if you don't have a chest seal, you're going to apply an occlusive dressing, but sealed only on 3 sides. Remove the chest seal and occlusive dressing if patient's conditions deteriorate. So how would you know the patient's condition is deteriorating? Well, when you look up here, it says list the signs and symptoms of tension pneumothorax.
Tachycardia, decreased lung sounds, hypotension, tracheal deviation, JVD.
All those are signs that the patient's condition is deteriorating. So if you detect the signs and symptoms of tension pneumothorax, you would remove the chest seal because you need that air to escape out more rapidly. You have to know the signs and symptoms of tension pneumothorax because if you don't know the signs and symptoms of tension pneumothorax, how would you know that the patient is experiencing tension pneumothorax? So let's kind of go back here. Once you remove the seal, because you detect signs and symptoms of tension pneumothorax or the patient's condition is deteriorating, you remove it, let the air expel out, but then you have to replace that occlusive dressing after the air has expelled from the chest. Verbalize appropriate mode of transportation, which is going to be ALS transport. And then on the backside, don't forget, there's a backside, verbalizes reassessment parameters. It's going to be a critical patient, so you're going to reassess conditions, look for signs and symptoms of tension pneumothorax or signs of the patient deteriorating every 5 minutes. Manages patient based on updated assessment findings appropriately. So this is going to be scenario dependent. So whatever scenario the instructor is interacting you with, you're going to adjust to that. If the patient's condition is deteriorating, we have to act on it. If it's improving, fine, we're just going to monitor and continue reassessing every 5 minutes. So that is the penetrating chest injury sheet. If you have any questions, just put it in the comments, and I'll see if I can get back to you guys. All right.